My name is Arnaud Lemmers. I'm working in the Erasmus Hospital in Brussels, and it's my pleasure to introduce you the last work that we published in Endoscopy, and I would like to thank the editors of Endoscopy for accepting our work. It is about local triamcinolone injection and selective adult oral steroid to prevent post-ESD esophageal stricture, which is a retrospective analysis of a prospective protocol in a Western center. So, of course, I would like to thank all my co-authors, Dorian Carpentier and Gael Englebert, who did all the analysis, as well as Lukas Otero, Anna Maria Bucalo, Laurine Verset, Peter Demeter, Pierre Zendrath, Jacques Devielle. The background is that if you perform a very large resection, the risk of stricture in the esophagus is present when we remove more than 50% of the circumference. And of course, if we increase to more than 75%, the risk is higher, 50 to 80% of stricture rate, and if it's more than 90%, more than 90% of stricture rate. Different regimens have been described to prevent stricture, like local steroid injection, oral steroid, and others, and you can see on the slide the rate reported from the literature on the use of those different regimens depending on the extension of the resection. So what we organize is to systematically from 2016 use the same protocol in the department. It means that for a patient with less than 50% of the circumference resected, there was no preventive method, 63%. Between 50 and 90% of the circumference, we injected triamcinolone in loco at the end of the resection, 59 cases. And in case of more than 90%, we injected triamcinolone locally and added oral steroids for 7 weeks with tapering down. It was the case in 8 patients here. As you can see, altogether, the stricture incidence in the whole cohort was only 8.4%. And it means that it's working very well. You can see that for more than 50% of circumference, it's 13%, more than 75%, 25%, and more than 90%, still 62.5% of stricture rate. As you can see, we have the Kaplan-Meier analysis of the strictures, and at 6 months with the endoscopic follow-up, we had altogether only a 10% cumulative incidence of endoscopic stricture. So the conclusions are that we validated a systematic stricture protocol with a single session of triamcinolone acetonide in local injection at the end of the resection for all resection more than 50% of the circumference. And we added oral steroid in case of more than 90% circumferential resection. The global stricture rate is very low, and especially when it was less than 90% of circumference resection extension. So since it's a single session treatment with no long-term potential systemic side effect, the triamcinolone injection method appears to be beneficial for patients and could be considered as a new preventive habit applied in Western countries. Thank you very much for your attention.